Hi, good morning, everybody, and very welcome to the Funda Friday. Today here, broadcast live from the CMH Family Medicine Boardroom. And we've been focusing mostly on topics that's related to people living with HIV and mostly with adults. And I'm very happy that we have Dr. Sowley with us here today, who has prepared us an excellent presentation on the clinical approach and guidelines to space occupying lesions in people living with advanced HIV disease. Huge thank you to Dr. Yusimi. That's always a powerhouse in the background to make sure that we have the most up-to-date information here today. I'm going to hand over to Dr. Sowley now. Just a reminder to please put your names and MP numbers or SAHCS numbers in the chat for attendance register purposes. Thank you very much, Dr. Sowley.
Good morning, everyone. As Dr. Miller has already said, I'm Soleto Sowley. I'll be discussing with you today space occupying lesions and guidelines, as well as a clinical approach to managing HIV positive patients, particularly with advanced HIV disease or suspected advanced disease, who present with central nervous system signs and symptoms, and how to manage them in our resource limited setting. This is a brief overview of what will be discussed. Epidemiology, introduction to the topic, general approach to these patients, and then I'll discuss some of the more common CNS pathologies and diseases in advanced HIV, and then finally an algorithm that we will use to approach management in instances where a CT scan may or may not be available to us. So HIV is a multi-system disease that causes chronic immunodeficiency and is thus complicated by opportunistic diseases and infections. There are approximately 7 million adults and children in South Africa living with HIV. It represents 18% of the population. South Africa is committed to the joint United Nations program on HIV and AIDS, known as UNAIDS, Global AIDS Strategy 95-95-95, which aims to, by the end of 2025, to have 95% of people living with HIV to know their diagnosis, 95% of them to be on antiretroviral treatment, and 95% of people to be virally suppressed. The prevalence of HIV, according to the data released by UNAIDS as of 2023, is 17.1%. The proportion of people living with HIV who know their status is currently 95%, on track with the 2025 target. Of those, 77% are on antiretroviral therapy and 71% are virally suppressed. Despite these efforts, almost 50% of people living with HIV continue to present with advanced disease. Upon presentation, often neurological complications or symptoms are sometimes the first and early manifestations of advanced disease. The most common space-occupying lesions seen in HIV are toxoplasmosis and CNS tuberculomas. As already mentioned, HIV is a chronic immunodeficiency disease. In confirmed infection, the World Health Organization classification for adults and adolescents and children over the age of 5 is according to clinical features and diagnostic findings. The clinical features that classify HIV are as follows. Stage 1 of the disease is asymptomatic. Patients may or may not also have accompanying persistent generalized lymphadenopathy, which is painless in 2 or more sites, excluding the inguinal areas, with no known cause persisting for 3 months. In stage 2, it's characterized by unexplained moderate weight loss, recurrent upper respiratory tract infections with sinusitis, otitis media, pharyngitis, as well as fungal infections, dermatological conditions such as seborrheic dermatitis, periodic eruptions, herpes zoster, and other oral lesions. In stage 3 of the disease, there's unexplained severe weight loss, unexplained persistent chronic diarrhea, unexplained persistent fever, persistent oral candiditis, oral hairy leukoplakia, current pulmonary TB, severe bacterial infections, unexplained anemia, neutropenia, and chronic thrombocytopenia. In stage 4 of the disease, patients have HIV wasting syndrome. It is also characterized by conditions such as pneumocystis pneumonia, Kaposi sarcoma, extrapulmonary TB, cytomegalovirus, HIV encephalopathy, esophageal candiditis, toxoplasmosis, chronic herpes simplex infection, and disseminated non-tuberculous mycobacterial infection. So because our discussion today is in large part around advanced disease and social nervous system complications that arise with it, I'll just expand a little on advanced HIV. It's diagnosed in patients with a CD4 count of less than 200 cells, or patients who are clinically at a World Health Organization stage 3 or 4, as outlined in the previous slide. All children aged 5 years or younger are automatically classified as having advanced HIV. Patients presenting for the first time can also present with advanced disease. Patients with treatment failure and subsequent decline in CD4 count, those that have defaulted treatment and returned to care after interrupting, may also represent with advanced disease. As HIV, advanced disease is associated with a high risk of mortality and morbidity, it is important to assess and work up all patients, new and those who have defaulted treatment for advanced disease. Although there are clinical manifestations that indicate advanced HIV disease, the best indicator is a CD4 count result, the value of which is less than 200, as I've already mentioned. And then advanced HIV is associated with increased healthcare cost, IRIS, opportunistic infections, and higher viral reservoirs. So our topic is around space occupying lesions. I'll just define them quickly. So a space occupying lesion is an abnormality that occupies excess space and volume within the brain parenchyma. CNS space occupying lesions are characterized by the presence of edema and swelling, and often can exert mass effects on surrounding structures. Space occupying lesions usually enhance after the injection of contrast, indicating local inflammation and breakdown of the blood-brain barrier. If a CT scan is available, these are some of the differentials that we look at in our setting. So TB or tuberculoma, toxoplasmosis, pyogenic abscess, neurocysticercosis, primary CNS lymphoma, secondary brain tumor, cryptococoma, nocardia, and syphilitic tumor. This will be a general approach to a patient presenting with central nervous system signs and symptoms, known with HIV or suspected with advanced disease. Of course, the most important step would be to, before taking a history, is to stabilize the patient, do a primary and secondary survey using our ABCs. You must ask the patient about constitutional symptoms such as fever, night sweats, and weight loss. These would be suggestive of disseminated TB or lymphoma. Brain abscesses or toxoplasmic encephalitis can also present with symptoms of fever. If the relatives or caregiver give a history of an acute or chronic decline in the patient's cognitive state, you can consider conditions such as HIV encephalopathy or progressive multifocal leukoencephalopathy. Patients who present with or give a history of new onset seizures would be suggestive of a space occupying lesion in adults or adolescents known with HIV. And of course, it's important to ask about TB exposure and any TB contacts at home, recent travel to TB or neurocysticercosis endemic areas. On the physical examination, it's important to do a thorough neurological and mental examination. Because this is a general approach, I won't go into the localization of lesions. You ask, assess for dysphagia, skin changes, oral thrusts, dental caries, and most importantly, to assess for signs of impending cerebral herniations and signs of raised intracranial pressure, which would be the Cushing triad of hypertension, bradycardia, and irregular breathing, as well as papilledema, headache, visual disturbances, and a depressed level of consciousness. This is important as these patients may need urgent referral to neurosurgery. Some of the tests and examinations, tests and imaging that we can do as part of our workup are HIV viral load, a CD4 count, syphilis, and toxoplasmic serology, serum cryptococcal antigen, bacterial and fungal blood cultures, gene expert urinary lab tests, and ultrasonography are also important in our setting. In terms of radiography, MRI scans are considered to be better over CT scans as they are more sensitive to detecting multiple lesions. They're more sensitive to white matter pathology and lesions that are located in the posterior fossa. They're also useful in identifying more peripheral lesions if a biopsy may be necessary. When scanning for a space-occupying lesion, both CT and MRI scan require pre- and post-contrast, which assists with differential diagnosis as some lesions enhance after the administration of contrast. So now I'm going to briefly talk about the most common space occupying lesions in our HIV population. I'll talk about the diagnostics and the general management of each. There's a high prevalence of tuberculosis in our setting, in particular affecting people living with HIV. TB is caused by Mycobacterium tuberculosis and in the central nervous system can manifest as meningitis, tuberculoma, spinal arachnoiditis, and transverse myelitis. 1 to 5% of TB cases result in CNS complications, particularly in areas of high prevalence, such as ours. This figure is 5-fold in HIV patients with TB. During the basilemia, which is when the TB bacilli are present in the bloodstream, tuberculous foci, also known as tubercules, are established along the brain, the meninges, and the cranial bones. A tuberculoma is, as a result, forms when these tubercules coalesce and form a granulomatous focus. Tuberculoma are often asymptomatic and may grow considerably without causing any meningeal inflammation or irritation. They present in adults and young children with headaches, seizures, progressive hemiplegia, and signs of raised intracranial pressure. In the presence of TB meningitis, a subclinical tuberculoma may be seen on imaging as an incidental finding. Tuberculomas may present in patients on antituberculous treatment due to the immune response against the dying organisms. On radiography, the findings are a small discrete lesion of between 1 millimeter to 5 centimeter. The lesions are ring enhancing. They have perilesional edema. There may be one or more. And in the early stages on the CT, they are hyperdense, hyper or isodense, with edema that is out of proportion to the size of the lesion itself, with little encapsulation. In later stages of the disease, the lesions are well encapsulated, iso or hyperdense with peripheral ring enhancement. These scans of a 6-year-old patient who presented with left-sided hemiplegia and seizures. In the first image, there's a calcified mass in the frontoparietal area. Image B is with contrast with ring enhancement around the border of the mass. The rest of the images are MRI scans of the same lesion. So in diagnosing CNS there should be a high index of suspicion in patients with a mass, as well as a history of TB, recent TB exposure, or recent travel to TB endemic areas. A confirmed TB diagnosis, particularly with extrapulmonary TB. But the definitive diagnosis is by needle biopsy of the lesion, which you send for histopathology, acid-fast bacilli, and TB cultures. However, surgical intervention is avoided as it can precipitate meningitis. Lumbar puncture is also avoided because patients may have raised intracranial pressure. But if a lumbar puncture were to be done, the CSF findings would be a normal glucose concentration, elevated protein, and a cell count, which would be lymphocyte predominant. The treatment for CNS tuberculoma is Rifampicin, which is rifampicin, ethambutol, isoniazid, and pyrazinamide for 2 months, followed by Rifanar, which is rifampicin and isoniazid for 7 months. Adjuncts to this therapy are high-dose corticosteroids for 4 weeks, and then that's tapered off over a course of 2 weeks and then stopped, as well as pyridoxine and Bactrim at 960 milligrams daily. Our next topic is toxoplasmosis, which is also one of the most common central nervous system infection in patients with advanced HIV not receiving prophylaxis. It's caused by the Toxoplasma gondii parasite. There's reactivation of the disease followed by some symptoms, especially in patients who have CD4 counts less than 100. It's transmitted through the ingestion of infections, oocytes from the soil, or undercooked or raw infected meat, cat feces, or vertical transmission from mother to child via the placenta. Clinically, patients with toxoplasmic encephalitis present with headache, confusion, seizures, focal neurological signs, decreased level of consciousness, and changes in mental state, which can range from dull or blunted affect to stupor or coma. And then toxoplasmosis can also affect other organ systems. Patients can have pneumonitis, where they can present with fever, dyspnea, and productive cough, chorioretinitis, where they present with eye pain, decreased visual acuity, and in disseminated disease, patients present with septic shock. Working up patients with toxoplasmosis, they'd be seropositive for toxoplasma IgG antibodies. MRI is the modality of choice in visualizing the lesions. There are multi-ring enhancing lesions with cerebral edema. Asymmetric target sign is pathognomonic for toxoplasmosis. And with contrast, the lesions are thin-walled, cavitating lesions with ring enhancement. This is an MRI scan of a toxoplasmic encephalitis. In diagnosing toxoplasmosis, the definitive diagnosis is by clinical presentation, identifying one or more of those lesions in imaging, and then biopsying the lesion and picking up the organism on biopsy. However, due to the high mortality and morbidity of surgery and biopsy, a presumptive diagnosis is done in patients with a CD4 count of less than 100 that have not been receiving prophylaxis, that present with signs and symptoms of toxoplasmic encephalitis, that have positive serology and suggestive brain imaging. In patients where an LP is safe to do, you can also send a toxoplasmic Gondii PCR, which will make the diagnosis even more likely. In people living with HIV, treatment includes antimicrobial therapy against toxoplasmosis, as well as antiretroviral therapy for immune recovery. Toxoplasmosis encephalitis, as well as extracerebral toxoplasmosis, is treated with the same regimen. The response in extracerebral disease, however, is not as favorable. The initial phase of treatment is largely to address the acute symptoms. If there's positive response to treatment, it continues for 3 months. The regimen in our setting is Bactrim. So we do have intravenous Bactrim available, which would be given at the trimethoprim aspect of it is 5 milligrams per kg twice daily. And the sulfamethoxazole is 25 milligrams per kg twice daily. And then orally, you give the 320, 1,600 milligram orally 12 hourly for 4 weeks. And then the 960 orally 12 hourly for 12 weeks. 3 months. Yeah. Patients on either one of these regimens do not require additional prophylaxis for PCP. In higher resource settings, this is a regimen that is used, which is sulfadiazine. Patients that weigh less than 60 kgs are given 1,000 milligrams orally 4 times daily. Weighing more than 60 kgs, it's 1,500 milligrams 4 times daily. If there's concerns about non-adherence, patients can be given up to 2,000 milligrams twice daily. This goes with primethamine, which is administered at a loading dose of 200 milligrams in all patients. And then again, patients who are 60 kgs or less get 50 milligrams per day. And then patients weighing more than 60 kgs get 75 milligrams per day, as well as adjunctly with leucovorin 10 to 25 milligrams daily to prevent primethamine-induced hematological toxicity. And then once patients have been initiated on treatment for toxoplasmosis, they need to be monitored for adverse reactions such as Stevens-Johnson's. They also need to be monitored for clinical improvement and response to therapy. Part of the monitoring also involves repeating the scan, which is done after 14 to 21 days to see if the lesions are shrinking in size. The next topic is cysticercosis, which is a condition caused by the pork parasite and tapeworm Taenia solium. It's transmitted fecal-orally by a human tapeworm carrier, and the incubation is 3 to 8 weeks. I'm sure we've all seen that life cycle. The clinical presentation depends on the localization of the cysticerci. Lesions can be in the brain parenchyma, extraparenchymal tissue, or both. Generally, lesions located intraparenchymally present with seizures and or headache, and lesions in the extraparenchymal tissues present with signs of raised intracranial pressure and altered mental state. Other organ systems that may be involved are muscle and subcutaneous tissue. Intraparenchymal neurocysticercosis is the most common, accounting for more than 60% of cysticercosis cases. Onset of symptoms is 3 to 5 years after incubation following infection and can present up to more than 30 years later. Clinical manifestations are influenced by the number, location, and degree of inflammatory response caused by the cysticerci. Seizures are the most common clinical manifestation. They can range from initially being focal with secondary generalization. In endemic areas, the most common cause of adult onset seizures is neurocysticercosis. Patients may present with headaches, but it's really the reasons that they seek medical care. They may also have visual disturbances, focal neurological signs, and meningitis. In extraparenchymal disease, it affects the ventricles, subarachnoid space, the spine, or the eye. It can also coexist with intraparenchymal disease. These patients present with signs of raised intracranial pressure, headache, nausea, vomiting, papilledema, and altered mental state. There's a high risk of mortality and morbidity in extraparenchymal disease. Neurocysticercosis can also affect the ventricles. These lesions are free-floating cysts within the ventricles, or they're attached to the choroid plexus. Symptoms develop when the cysticerci become lodged in the ventricular outflow tracts, resulting in obstructive hydrocephalus. Patients present with signs and symptoms of raised intracranial pressure, altered mental state, and a decreased visual acuity. Less frequently, seizures and focal neurological deficits may be seen. In mobile cysts that are found in the third and fourth ventricles, they may cause intermittent obstruction, leading to episodes of sudden loss of consciousness associated with head movements. This is known as Brown syndrome. Subarachnoid neurocysticercosis. It's infrequent, but is the most severe form. Lesions are found in basilar cisterns. It's associated with chronic arachnoiditis and mass effect due to the enlargement. Chronic arachnoiditis is associated with communicating hydrocephalus, vasculitis, meningitis, and stroke. Cysts may grow up to 10 centimeters. In diagnosing neurocysticercosis, it's done on clinical suspicion. Patients that present with seizures, signs of raised intracranial pressure, and that have been exposed in endemic areas, or there's a known member in the family that's asymptomatic. Imaging, where you'd see multiple cystic lesions, enhancing lesions, or calcifications. And particularly in CT scans, there's a scolex with a cystic lesion, which is diagnostic of neurocysticercosis. And then the diagnostic criteria is as demonstrated in this table. The absolute criteria is histological demonstration of the parasite from a biopsy of the brain or spinal cord lesion, visualization of subretinal cysts, conclusive demonstration of a colex within a cystic lesion on neuroimaging. Major criteria on imaging is cystic lesions with no discernible scolex, enhancing lesions, multilobulated cystic lesions in the subarachnoid space, typical parenchymal brain calcifications. Confirmatory criteria are resolution of cystic lesions after cystal drug therapy, spontaneous resolution of single small enhancing lesions, and migration of ventricular cysts documented on sequential neuroimaging studies. Minor criteria are obstructive hydrocephalus or abnormal enhancement of basal leptomeninges. Clinically, the major criteria are detection of specific anticysteral antibodies or cysterical antigens by well-standardized immunodiagnostic test, cysticercosis outside the central nervous system, and household contact with tinea solium infection. And then minor criteria are clinical manifestations suggestive on neurocysticercosis and individuals with prior or current residence in an area where cysticercosis is endemic. And then in diagnosing, there must be one absolute criteria or two major neuroimaging criteria plus any clinical epidemiological exposure, or one major neuroimaging criteria and confirmatory imaging criteria, plus any clinical epidemiological exposure criteria. A probable diagnosis of neurocysticercosis is established by any one of the following, which is one major neuroimaging criteria plus any two clinical or epidemiological exposure criteria, or one minor neuroimaging criteria plus one major clinical epidemiological exposure criteria. And then managing neurocysticercosis. In the acute phase, the symptoms should be managed. Initiation of antiparasitic therapy is not always urgent. Antiparasitic therapy is contraindicated where there are signs of raised intracranial pressure. So acutely, if there's diffuse cerebral edema seen on neuroimaging, patients are given dexamethasone at a dose of 0.2 to 0.4 milligrams per kg per day. If patients have obstructive hydrocephalus, surgical removal of obstructing cysticercosis or placement of an extraventricular shunt or drain. In communicating hydrocephalus, cerebrospinal fluid diversion via a VP shunt or third ventriculostomy. And then in managing seizures, anti-epileptics are obviously the mainstay of treatment. Even if the patient has only presented with a single seizure, they need to be started on anti-epileptics. The choice of anti-epileptic is based on the availability, the cost, the drug-to-drug interactions, and potential side effects. Most commonly used are phenytoin and carbamazepine. These are just images of what neurocysticercosis looks like on CT and MRI scans. And then prior to the initiation of therapy, all patients need an ophthalmological examination and TB screening. The benefits of therapy are there's faster resolution of active cysts, there's decreased risk of seizures, decreased risk of recurrent hydrocephalus. The risk of therapy are exacerbation of neurological symptoms due to inflammation around degenerating cysts. Indications for therapy are viable and or degenerating cysts on neuroimaging. Contraindications are untreated hydrocephalus, diffuse cerebral edema, and presence of calcified lesions. Antiparasitic therapy is only indicated in patients with active viable cysts, as I've already mentioned. In patients with calcified or non-viable lesions, there's no role for antiparasitic therapy. And in these instances, you only treat the symptoms that they have. Treatment includes albendazole with or without praziquantel. So patients weighing more than 60 kgs are given 400 milligrams 12 hourly, taken with food for 8 days. Patients below 60 kgs are given albendazole at a dose of 7.5 milligrams per kg 12 hourly. The maximum dose you can give is 800 milligrams taken with food, also for 8 days. In some instances, you can add praziquantel at a rate of 50 milligrams per kg in divided doses of 3. Treatment can be given for up to 14 days. Adjuncts to the treatment are prednisone, 60 milligrams orally daily, 60 milligrams orally daily for total duration of the antiparasitic therapy that you'd be giving. And then corticosteroids should always be administered with antiparasitic therapy. They're found to be associated with fewer seizures. You give 1 milligram per kg per day and dexamethasone at 0.1 milligram per kg per day. The treatment duration is the duration of the antiparasitic therapy. Brain abscesses. A brain abscess is a focal infectious collection within the brain parenchyma. It's a complication of another infection due to trauma or surgery. The bacteria invades the brain either by direct spread or hematogenous seeding. Location reflects the site of primary infection. Common sites are the frontal lobe, temporal lobe, frontoparietal region, or the parietal lobe. 25 to 50% of cases happen by direct spread due to dental infection, frontal or ethmoid sinus infection, otitis media or mastocytitis, foreign body, or surgical procedures. 20 to 35% of cases are by hematogenous spread, commonly in the distribution of the middle cerebral artery. Conditions that lead to hematogenous seeding in the brain are immunocompromisation, chronic lung infections such as lung abscesses and empyema, skin infections, pelvic infections, intra-abdominal infections, infective endocarditis, and congenital cyanotic heart diseases. Clinically, patients present with headache localized to the side of the abscess. They are gradual or sudden, and pain is severe and not alleviated by analgesia. Sudden worsening of headache accompanied by onset of meningism may indicate rupture of the abscess. Some patients may present with neck stiffness, in occipital lobe abscesses or leakage into the lateral ventricles. They also may present with change in mental status, which can range from lethargy progressing to coma due to severe cerebral edema. These patients usually have a poor prognosis. Vomiting is due to raised intracranial pressure. They may present with fever, but only in about 50% of cases. They also present with focal neurological deficits and seizures. So the neurological deficits and brain abscesses are determined by the location of the abscess. So in instances where the abscess is in the temporal lobe, patients may have Wernicke's aphasia, homonymous superior quadrantonopsia, which is decreased visual acuity in 3/4 of the eye, and then mild contralateral facial muscle weakness. In the frontal lobe, they are presenting with drowsiness, inattentiveness, disturbed judgment, mutism, seizures, presence of grass suck and snout reflexes, and contralateral hemiparesis. In parietal lobe lesions, they have impaired position sense, two-point discrimination, and stereognosis, focal sensory and motor seizures, ominous hemianopia, impaired optic connected nystagmus. And then in cerebellar abscesses, they have ataxia, nystagmus, and ipsilateral organ incoordination. In brainstem abscesses, they have facial weakness and dysphagia, and multiple other cranial nerve palsies. These are some images of what brain abscesses look like on CT and MRI. Pyogenic abscesses have a double rim sign with the outer hyperdense and inner hyperdense appearance. The thin medial border with satellite lesions is pathognomonic. Treatment for brain abscesses is ceftriaxone 2 grams IVI 12 hourly with metronidazole, either 500 milligrams IV 8 hourly or 400 milligrams if given orally. And then urgent neurological surgical intervention is needed for drainage and culture of the lesion, which will determine the organism, the sensitivity, and therefore further antimicrobial treatment to be adjusted according to the pathogen that is found. And then in managing our patients with space-occupying lesions, they common in advanced disease, as I've already mentioned. They present with evolving or worsening, neurological signs and symptoms. And in a resource-limited setting such as ours, where CT or MRI scans may not always be readily available, it's sometimes difficult to diagnose and manage. So when the patient first presents, you need to assess whether they need urgent referral to neurosurgery or not. So if they have obstructive hydrocephalus, signs of impending herniation, mass effect midline shift with depressed level of consciousness, or have a pyogenic abscess on CT. If there are no clear pathognomonic signs of neurocysticercosis, then you must consider starting TB or toxoplasmosis treatment. Before this, you must take a full history and examination, do a chest X-ray, CD4 count, and a reflex cryptococcal antigen, as well as toxoplasmosis and syphilis serology. Patients must be worked up for extraneural TB using a ULAM, gene expert, and abdominal ultrasounds. A lumbar puncture when it's safe to do so. CSF must be sent away for cryptococcal antigen, TB expert ultra, TB cultures, syphilis serology, and Epstein-Barr virus, and CT scan. While you wait for those results, patients must be started on cotrimoxazole for toxoplasmosis. If the CD4 count result is more than 200 and you have that result available to you, you must start TB treatment instead. If the CD4 count is still unknown and you're considering starting empiric TB treatment anyway, this should be done in critically ill patients with lesions in critical areas such as the brainstem, with significant edema and midline shift. TB treatment with steroids is helpful. If you decide against TB treatment, steroids should not be added to toxoplasmosis, as it will alter the follow-up CT scans, and it won't be clear whether the improvement is from the steroids or if you've made the right diagnosis of toxoplasmosis. If you're querying a pyogenic abscess, the patient must receive 2 grams of ceftriaxone IV twice daily and metronidazole. And as I've mentioned, consult neurosurgery for possible drainage. Pyogenic abscesses in the brain may not present with fever. They may not also have a raised white cell count or CRP. And then you adjust as you go. At this point, your patient will be either on TB treatment, toxoplasmosis treatment, steroids, or treatment for pyogenic abscess. As results become available to you, you adjust your treatment accordingly. If the serum CRAG is positive, you treat for cryptococcal meningitis, but you don't stop any of the other treatment that you've already initiated. The lesions may or may not be cryptococcomas. Once the toxoplasmosis results are out, and if they're negative, you can then stop the cotrimoxazole treatment that you would have initiated. And then once the CD4 count results become available, if the CD4 count is above 200, you can also then stop the cotrimoxazole, as toxoplasmosis is unlikely in this instance. You then start TB treatment if you have not already done so. Syphilis results. If you have a positive TPHA and RPR, you consider the diagnosis of neurosyphilis. You can do an LP if you haven't already done so. And if the patient has a high RPR titer, then you can start empiric treatment for syphilis. But still, you don't stop any of the treatment you've already started. After about 2 weeks of having started the treatment that the patient would be on, and you haven't already excluded toxoplasmosis, you must repeat the CT brain. If the lesions are unchanged or worsening, you must stop the cotrimoxazole and start or continue TB treatment, depending on what you've already done at this point. If the lesions are shrinking, you continue with the cotrimoxazole. If the patient is also on TB treatment, it's best to continue with this as well. Repeating scan is not indicated if positive response to treatment is noted. If poor response, you must repeat the scan after 2 months. And then if patients are not responding to treatment, you must consider non-adherence, iris, poor CNS drug penetration, drug-resistant organism, malabsorption of drugs, and then consider that the diagnosis is not toxoplasmosis, TB, or nocardia. At this point, you should discuss with an infectious disease specialist. Do CSF for Epstein-Barr virus, and then also test the CSF for JC virus. You should, with consultation with the neurosurgeons, you should biopsy the lesion as well. And then when patients present to you with CNS signs and you don't have a CT scan available to you, again, you take a full history and examination, you look for signs of endocarditis. If there's focal neurology and it's a sudden onset with a hemi, you consider that the patient may have had a stroke versus if they've had gradual worsening weakness, in which case then the most likely diagnosis is a growing mass. You check the glucose, you do the renal and liver function test, you do a chest x-ray. If you're suspecting a space-occupying lesion, it's best to avoid an LP because you wouldn't have a CT brain available to you. You do a CD4 count and a reflex CRAG, as well as toxoplasmosis and syphilis serology, a ULAM, abdominal ultrasound, and a gene expert. You then start treatment for toxoplasmosis and TB. You only add steroids if patients have severe neurological signs and symptoms. If the results come back with a CRAG positive, you add treatment for cryptococcal meningitis. Again, you don't stop the treatment for toxoplasmosis and TB that you've already initiated. You'll only stop cotrimoxazole if the CD4 count is greater than 200, because, as we've mentioned, toxoplasmosis is probably unlikely in this scenario. You also only stop TB treatment if there's no evidence of extraneural TB or the symptoms improve after 2 weeks without the use of steroids. A delayed scan can still be useful for diagnostic reasons and as a baseline for further management. And then this is an article that was published in 2018. It's a retrospective study that was conducted in KZN that demonstrated that the most common CNS conditions in HIV population were toxoplasmosis and tuberculoma. Most patients presented with seizures, confusion, and altered mental state, headaches, and focal neurological deficits. But most importantly, the early initiation of TB and toxoplasmosis treatment yielded better outcomes for all patients. So the take-home message is that patients must continually be assessed and screened for advanced HIV and for preventative opportunistic diseases. They must be provided with appropriate prophylaxis in those that are already found to have advanced HIV disease. Ongoing counseling for treatment adherence and lifestyle modifications. And in all these conditions, once the CNS pathology has been treated, patients need to be reinitiated on the ARVs when it is appropriate. It ranges in some conditions from 2 weeks to 4 weeks. And then when in doubt, discuss with a senior available infectious disease specialist and other colleagues. Thank you.
Thank you very much, Dr. Sali, for a very comprehensive presentation of this topic. Very much appreciated. I'm going to open the floor now for questions and comments, both from the audience here at CMH, but also if you do have any questions online, please put them in the chat, or you can also put your hand up. And for those of you online, please remember to add your HPSSA numbers and names. I just want to make two small comments. The one is when you were mentioning now about restarting ARVs. So the reason why we mentioned that is because the majority of patients who actually present is going to have advanced HIV disease, and it's either people who haven't been diagnosed or people who defaulted out. But obviously, if somebody's already on ARVs and are presenting with a lesion, you wouldn't stop the ARVs. So just to clarify that. But yeah, so the majority of patients we would see would not be on ARVs. You would therefore first sort out the condition, and then you would start the ARVs depending on when the on what the diagnosis is. And for example, with conditions like cryptococcus and TB, we would wait 4 to 6 weeks before we would start our ARVs. And the only other comment I want to make is about seizures, first presentation seizures when you're out in the community or out in the districts, and the extreme importance in the South African setting to get an organized scan. You don't have to get it on the same day. You don't necessarily have to get it within the same week. But if you've had somebody with a seizure, you need to start organizing to refer them up to a central, somewhere centrally, where they're able to do a CT scan for their patient. We can try and do the empiric treatment route. It is not ideal. And I think every patient with a first seizure deserves to have a CT scan. So in a developed world where it's more likely just to be epilepsy, one can wait for a second seizure to start investigating. But I think in a South African setting, all of these patients do deserve to get a scan. So try and make that possible. Are there any comments? Dr. Yusimi?
Yeah, thank you very much for the presentation. I think that since the implementation of the UTT in 2016, the incidence of this serious condition has been decreased considerably, okay? But unfortunately, we still have people that present very late for initiation on treatment, people who default to medication, people who are failing the regimens. So we need to have a very good strategies, okay, or system in place to try to trace all of these patients, okay, to come back on regimen, okay, to try to make the habit of ongoing screening according with any medical condition. So it doesn't matter that the patient is hypertension and coming for family planning, whatever. Offer the ACT to all of our patients. And I really want to take this opportunity to appreciate the effort made by all of our infectious disease specialists in the development of the algorithm to approach all of these complicated diseases according with our resources and our setting that we're currently working. So I recommend to all of our colleagues to go back and read this clinical guideline for hospitalized adults with advanced HIV published in 2022 by our HIV Clinician Society.
Thank you very much. Yes, that's a great reference. So just to reinforce that, please check out your AHD guidelines. What's amazing about the AHD guidelines is that each of the chapters has been written by an infectious disease consultant, and they are very practically written. So it's actually a lovely approach on all kinds of different aspects of advanced HIV disease. And this is one of the chapters, I think, was written by Dr. Tom Boyles, wrote this. And yeah, but I think he wrote this particular chapter was from Dr. Tom Boyles. Any other comments from CMA? I don't see any hands online at the moment or any comments in the chat. Yes, and Dr. Adene, thank you.
Yeah, thanks for the presentation. I think mine is just about prevention. Largely, we still want, like Dr. Yasimi highlighted, that the gateway to diagnosing these patients is to have visits done. And as clinicians, wherever we are placed, we should be proactive in terms of actually bringing to the fore provider-initiated counseling and testing so that we can actually be able to pick patients early. And more importantly, for those patients with low CD4 count, especially CD4 count below 200, Bactrim actually will prevent a number of these very terrible diseases. And I think as clinicians, when we review these patients, we need to make, we need to prioritize assessing that the latest CD4 count is above 200. More importantly, they are on ARVs and they are adhering to their treatment and they are virally suppressed because, again, CD4 counts and viral load, they are more of a snapshot of what is happening in terms of the progress of the disease. And therefore, if patients are not adhering, the implication thereof is that the viral load within 2 weeks will reach pre-treatment level, and the CD4 count is going to drop precipitously. And the implication thereof is that it may take some time before opportunistic infection sets in. Critically, in every clinic visit, we need to be checking all of these things to be sure that our patients are still sticking to their treatment. But more importantly, the prophylaxis, Bactrim, especially for toxoplasmosis, we need to be very aggressive and be sure of that. There are other concepts, especially in pregnant women. I was just looking at there are 2 conditions, both tuberculoma, especially TB in the last phase of, towards the delivery in pregnant women. Together with toxoplasmosis, both of them have got predilection for congenital transmission. So babies, in fact, can actually be infected, there can be congenital transmission of both toxoplasmosis and TB, in the last phase in pregnancy. And the implication thereof is that those babies, when they are born alive, obviously within the first few months, they will end up with fissures CNS infection in the babies of these mothers. So we need to be very, very critical, aggressive in terms of how we manage these patients. And of course, TPT for those who have not been diagnosed, who have been, after screening that they are negative for TB, then TPT should be initiated. Okay. The other point is that all of these terrible conditions will need to be managed at a central hospital or at the minimum of a regional hospital. The approach to diagnosis of these conditions depends on resources that are available. Very rarely would we need to do a biopsy on the brain of any patient who is still very active. So invariably, it simply depends on the experience vis-a-vis CT with contrast so that we can then make a decision. A third of those patients with TB meningitis who may have tuberculoma. In addition, we expect a third. There's a rule of 1/3 of those patients who have got extrapulmonary TB. We equally have concomitant pulmonary TB. And therefore, we don't isolatedly just pursue only the brain. We equally must pursue the lung in the chest of the patient so that we can have a way of discriminating tuberculoma from other features or other probable etiology. The only other one, which ideally would be easy to diagnose, would be cryptococoma. It just equally causes, which is part of the spectrum of cryptococcal meningitis, in which case they equally have those lesions in the brain of those patients. So, but that becomes very easy based on our CSF finding. But by and large, the blood level of the patient will equally be positive for that particular condition. So by and large, those are just few comments. We should largely focus on.
So I see there's a question online on the chat about what do we do for patients who are allergic to cotrimoxazole?
There are a couple of other medications. I'm sure she yes, just
Dr. Yeah, okay, good. Let me just hand over to Dr. Sowley, yes, in terms of what we do for patients that where we cannot use okay. Dr. Yusimi, do you want to step forward?
Yeah.
Okay, Dr. Yusimi has got it there. She's coming.
Okay, so we have the option to put the patient on clindamycin plus pyrimethamine, or the other choice will be dapsone with pyrimethamine. The problem is the pyrimethamine is a drug that is level 5 or 6, okay? So this patient need to be obviously referred to a special center. And the other thing will be to send the patient for the desensitization. Okay, this one is more complicated in our setting.
The other option is pentamidine.
Pentamidine, yes. So your more tertiary level drugs. Great. Thank you very much. Very good question. Excellent. I don't see any other questions or hands this side. Everybody here happy? Great. Thank you very much. We are going to close this meeting. A huge thank you to Dr. Sowley and Dr. Fuentes for putting all of this together. And I hope you all have a lovely weekend. We'll see you next month.